Um, well, since you pulled that up, do you just want to start off by just describing what that is?
Okay, so I wonder. Okay, so this is this is a radiation therapy treatment plan. So what we do is for patients coming in, what we will do is we will design a treatment that is patient specific. Mm-hmm. So what we do is we learn where the cancer is, and then we also map where all the very sensitive organs are. So in this case, we have a spinal cord. What relates to Haley's project is we also map where the parotid glands are, which are the salivary glands. Mm-hmm. And that patient will receive a treatment designed just for them. So, and all of these things, it's always a balance of giving enough radiation to kill the cancer, but minimizing radiation everywhere else to, essentially to maintain the patient's best quality of life that's possible. Okay. And this is an example of this. So in this case, I'll just go a little bit higher. In this case, what you can see is we have fairly high levels of dose around. This is our target. These are our targets while we miss areas that we do not want to hit. Essentially, everywhere where the tumor is not, but we take special care around specific organs.
Can you just turn off the dose for a second, just to show them?
And again, these are all these things right here we list are important. So these are either targets mm-hmm. or things we specifically do not want to hit.
Okay, so that's not actually showing the cancer, is it? Or?
No, but and this one we won't be able to, but the cancer will be shown a couple different ways. So in conjunction with this, they'll have PET imaging, MR imaging, diagnostic CT. Mm-hmm. So a plethora of, and in a normal patient, we would be able to show you, like we could show you them. Those are attached to it, but because this is an anonymized data set, we only have the parts that we need.
Fair enough. And we can take pictures of this one?
Yeah.
So even before you actually publish it, can you just phone back, mm-hmm. and I'll just make sure that that's gone through our
Sure.
Just the pictures, or?
Yeah, just the pictures.
We can send you the project, and you can look at it.
Yeah.
Right.
Yeah.
And I think that this is okay. Like, this is an anonymized data set, but I would like to run it
just
through our
case.
Communications piece.
For sure. Yeah, for sure. Okay. So, just relating to your research, why do you think the saliva aspect is important, or specifically saliva?
So, a lot of patients that get radiation treatment in the salivary gland region end up with xerostomia. And it's quite, I've been told that it's quite painful. Mm-hmm. It's difficult to eat, sleep, swallow, speak, just generally uncomfortable for patients. So we thought, or rather, this project was set in motion before I was even here, but I was anxious to get onto it because I felt that there was maybe something that we could do, mm-hmm. really come up with a set of rules to reduce the amount of uncomfort these patients were encountering.
Yeah. Cool. Yeah, we actually looked into the xerostoma aspect of it, which was, we were surprised as well.
Yeah, some of the images are quite graphic.
Mm-hmm.
A lot of discomfort.
Yeah. So in relation to that, how does the radiation specifically affect the saliva loss?
So there is a correlation that we found that links the amount of radiation given almost mean dose of the entire gland to the amount of loss in terms of saliva that a patient encounters. So there's a very highly correlated link between those two. But in terms of what actually is happening at the cellular level or even the duct level, we don't know yet. Mm-hmm. That's something that we're currently looking into.
Okay, so it was just the general picture that you guys found.
That's right.
Okay.
Yeah, that's right.
Okay.
Yeah, unfortunately, we couldn't find anything more specific.
Okay.
We were looking for a smoking gun and didn't find it.
Okay. Okay. So then, just wondering, how did you guys measure the dose to the parotid and then the saliva output? That.
So saliva output is easy. I've been told, I haven't actually seen it done in person, but there's a dentistry department downstairs where they ask patients to lean forward.
Mm-hmm.
They have a little block of wax that they put in their mouth,
Okay.
and then they ask them to spit in a cup for 5 minutes.
Oh.
It's very simple.
Wow. Okay.
So that's where that measurement comes from. In terms of the dose to the glands, we don't actually have a measurement of the dose. We have expected dose, like a planned dose that should be, I think it's within 5% or so.
Better than 5%.
Is it
I would
the
say
actual
it's
version?
probably within 1.5%.
Okay.
Of their actual dose.
That's right.
Okay.
So this like what I
That's-
showed you here is a calculation of the dose, but the calculation algorithm, at least in this kind of situation, extremely accurate.
Okay. And then we were just wondering, because we researched it and we found that there were 3, I think, salivary glands. So we were wondering why just the parotid
Why
gland.
the parotid? Yeah, so you're right. There's actually more. There's the sublingual, submandibulars, parotids, and then all throughout the oral cavity, there's all these little, very tiny, almost like little clusters of cells, but just a handful of cells.
Mhm.
And those are all distributed across the palate and whatnot.
Okay.
But the parotid is really responsible for on-demand saliva. The submandibular is primarily the one responsible for at-rest saliva.
Mm.
So when patients go to eat or speak or do something, the parotid really is the one that should be supplying the saliva.
Okay.
So, yeah, there are other indications that it would be worthwhile to look at the submandibular, but the parotid is certainly the number one.
So even during eating, it would be the.
They would be primarily the parotid during eating.
Okay.
Yeah.
Interesting. Interesting. Okay.
Another main reason it was the easiest one to query.
Okay.
Because the submandibulars are resting saliva, there is no obvious way. You would have a very hard time challenging them. Like, so essentially getting them to work for you to actually be able to take a measure.
Okay.
We're currently looking at more sophisticated techniques where we are looking how to challenge them, but that was the primary reason.
Okay. So did you guys come up with, or potentially other ways that you could be measuring the saliva other than just the spitting?
Whole
in the
mouth?
cup?
Actually, yeah, we recently came up with a little scheme. Well, we didn't come up with it. We have a colleague from Denmark, I believe. Anyway, she sent us plans that they have for these little suction cups that stick over the ducts in your mouth.
Okay.
So the primary means for parotid saliva to get in your mouth is a duct on your rear back molar called the Stenson's duct. And these little cups will actually just sit on the duct and collect all the saliva that comes out.
Oh.
So we haven't put those into practice yet, but we have thought about it.
Yeah. That would definitely be more efficient.
Yeah.
I mean, it won't be actually more efficient at whole mouth saliva. You produce as much as you produce, and whether we whether we kind of vacuum it up or have someone spit it out, what we'll get out of it that we'll be able to check parotid specific saliva. So how much the left parotid is giving versus the right, and the way we did it, we could only check whole mouth saliva.
Okay.
Yeah, as it stands, the submandibular puts out about 30% of saliva even when the parotid is engaged.
Okay.
So there's a little bit of uncertainty there.
Okay. Do you guys have questions you want to ask?
I just wonder, how do you choose which patient do you collect, or are they voluntary to do your experiment, or how do you choose them?
I think maybe Stephen could answer this in more detail, but my understanding is that patients are pretty much brought on, and then if they're excluded for some reason, then they're not allowed to participate. But
So yeah, there's a number of. So first they have to consent to be part of the study, and then after this, what happens is they are excluded depending on what their treatment has. So essentially, any kind of thing that might interfere with, with our analysis of the result. So if they've had surgery on one of their carotids, that's out, and if they've had a chemotherapy, that's out. All the things that would essentially would dirty, like muddy up the waters for what we want to see. Yeah.
Okay.
If a patient says they don't want to participate, then I never hear about it. The patients were not aware that they've even said no.
Okay.
And if they decide they don't want to do it halfway through, then they can, retract out the study at any time as well.
Okay. So we were wondering if a patient were to receive a lower dose of radiotherapy, would it be as effective as reducing the cancer, or not?
Definitely not. The main kind of issue of contention is that you have to deliver enough radiation to kill the tumor, but you don't want to deliver too much radiation to the nearby tissue. So reducing the amount of dose is definitely not going to be possible for most cases.
So the trick here, at least the trick that we were looking for, is if you can maintain parts of the parotid gland, can we selectively plan to save certain parts of the parotid to maintain function? And what this would do is it would give us a little bit more information. So on something like this, we could be a little bit more specific and say, just save this part, and we have a good idea that this patient will do a little bit better, versus trying to save the whole parotid, where we would also have to sacrifice the tumor as well, like dose to the tumor, which we can't do because then it will reduce the efficacy.
And then, is this the kind of stuff that doctors actually use in the hospital to provide dosage for radiotherapy?
This is exactly what they use. So this
Okay.
this was someone who got treated with this exact thing.
Okay.
I wonder what is the scan? Is it like some CT or?
This itself is a CT study. So it's a CT, and then what we do is we optimize the plan on this specific patient. So what you can see there is they have dentures or fillings. That's caused by that. But
So for each patient, you have to take like a bunch of scan to figure out where are the tumor. Yeah, before you treat it.
every treatment we do is different. Everyone is for that exact patient at their time. So it's a bunch, like it's this with some functional imaging on top of it, and then the radiation oncologist will also what they'll contour is nodal volumes, places where the cancer might go or where it's likely to travel. But every treatment is for that patient.
Okay.
So if you see another one, it might look similar, but again, this is that person, and this calculation is done for this person, like this exactly, and we won't apply this to anybody else.
I know that you said you took out patients from the study that had certain conditions. So, say if they had parotid gland surgery or something like that. So, based on that, I'm assuming that you're concluding that this research is the saliva loss is due to the radiation therapy and nothing else.
That's right. It's what we're hoping to isolate.
Okay. Okay. And that was done using just eliminating the patients based on.
Yeah, easiest way to account for it. It's just to get rid of the patients that factor changed.
Okay. So in terms of just cancer treatment, so things like chemotherapy, where does radiation therapy stand? So in terms of popularity, in terms of effectiveness, where does radiation therapy stand compared to other?
So I'm not an expert exactly on chemotherapy and the other modalities or treatment options, but I know that radiation therapy is quite cheap compared to chemotherapy, and it's also fairly quick and can also be quite localized. So if a patient has a tumor somehow on like the periphery of their body, um, it wouldn't really make much sense to have chemo because that would be a whole body treatment.
Okay.
Whereas radiation therapy, you could target that region and kind of isolate it to the region.
Okay.
I'll put in that it's site dependent, right? So someplace the efficacy is really great, and some it's not. But all of these things fit kind of fit together. So it's optimized depending on what's essentially what's best for that patient. So I think probably still the primary method of curing most tumors is surgery. I believe that's followed by radiation therapy as what's considered the primary cure, and then chemotherapy, which is sometimes given as adjuvant, but in some cases it's the primary cure as well. And each of these things has their place, like depending on where you get it and what the type of cancer is, and that kind of thing.
Okay.
I agree with my grad student that it is relatively inexpensive compared to some of the other modalities, but that is not the primary reason for a decision. What they do is they do radiation therapy where radiation therapy is best. In this type of treatment, it works quite well.
So, for head and neck patients, would it be radiation therapy, or does that also depend on where the cancer is located?
So these folks will either get they'll get a combination of radiation therapy and chemo, or radiation therapy, depending on that specific patient, their cancer, the extent of that cancer, and that kind of thing.
Is there much surgery that happens?
I could not comment on the amount of surgery that happens for a head and neck cancer.
How does the radiation therapy, like, how does it work? Or in basically, like, does it kill the cancer cell but not the normal cell, or?
So this can be very complex, depending on how you're looking at it. But the idea is you have to take this. I mean, it's specific depending on the type you do it, like the type you look at it. But generally, the common thought is you do DNA damage to a cell, and if you do enough DNA damage, the cell can't repair. So if you get the dose high enough, the cell won't repair and it will die. You have, again, depending on how you administer it, you have a number of other things going for it. Generally, you have healthy tissue will repair better than cancer cells. So depending on how you give it, you can kind of allow healthy tissue will keep repairing itself while the cancerous tissue won't be able to. So you can give close to the same amount and the healthy tissue will recover, but the cancerous tissue will not.
So but the recovery itself is, when it can recover if it's not damaged, but if the DNA is damaged, then under mitosis is when it can no longer proceed, and it's just apoptosis. So the cell dies. That's how the actual cell death occurs.
Okay.
So the cancer cell are more likely to die as a result of radiation therapy compared with the normal cell. Okay.
It depends on how it's administered. So we also administer a different type of therapy where essentially you can you kill everything in the volume, but we know everything within that volume is cancerous, so we'll apply it differently. What we'll do is we'll increase the dosage.
Okay.
And this, like for some small lung cancers, this has been also very successful, this type. But for this type of treatment, we do rely on a kind of fractionated approach.
So just to maybe clarify, if the patient volume is like this, like a cross-section volume, we'll send a beam through like this, maybe one direction, send another beam like this, send another beam like this, send another beam. And if the tumor is in this overlap region, then they receive a lot more dose, or the tumor receives a lot more dose there. But because the beams are spread out in the normal tissue, they receive a lot less dose. So less cells will die there, but because of the beams overlapping there, there's a high dose in that region. So
I see.
Okay.
And normally, how many times do the patient need to undergo this treatment before it is finished?
Generally, it's 35 fractions. So they come by at 35 separate times for treatment, not including the initial planning stages and checkups and whatnot.
35 times, like in the duration of how many days normally?
I believe it's 5 days a week.
For this, 5 days a week, yeah. So they come every day. It's about 15 to 20 minutes, including, like, in this kind of case, because we're there's a lot of setup. So we do a lot of things, like we also will image them while they're on the bed. So the getting geometric accuracy on this, like making sure they're exactly in the same position as how we plan them to be is quite important. So 35 times and about 15 to 20 minutes per time.
About a month and a half. Yeah.
Could stem cell could be a solution to this problem, maybe into the future?
So,
That's
sorry.
far away, is it?
No, it's actually I don't, it is not that far away. The efficacy of it is still under debate. So you're talking about for the parotid or
Yeah.
for the cancer itself?
The sublingual or any other tissues that secretes the saliva.
Yeah. So this kind of work's been done in rat in the rat model, not by this group, but was also one of the this idea of a heterogeneous response for the parotid comes from part of it comes from some work that was done with stem cells.
Okay.
So if we're lucky, we can figure out a way to do it without, but doing it with it's being worked on.
Okay.
So it might be an option. It might be the best option, or it might be an option that we don't need to do.
So if after the 35 treatment, if the patient doesn't respond well, do you continue or you just stop it?
Yeah, no, we have after the treatment, the patient's monitored, and if they do come back, they can be retreated. It depends.
Okay.
Everything on this is catered to that individual patient. But for this specific treatment will not go beyond 70 gray, which is our measurement of radiation, and in 35 fractions.
I was just wondering, has the xerostomia actually caused patients to retract from treatment, stop taking treatment, or in any case that you've noticed, reduce?
Not in any case that I'm aware, but
I wouldn't, unfortunately, just because of my job, I'm not privy to that. So that's the conversation that they would have with the MD that is working with us, Dr. Wu. He could answer this, but these would always be in consultation with him, so they never come see.
Yeah.
They never come see me
Okay.
to talk about their.
although I have heard about fluoride gels and things that are prescribed. So maybe I of course don't know either, but I think my impression would be that they would continue along and just treat the symptoms as needed
Okay.
for the prospect of killing the cancer, of course.
Yeah. Okay. Do you guys have any questions? No?
Is it possible for us to look at the equipment for you to do the radiation therapy?
Sure, we can.
I did clear that with HR.
Okay, great. So what we'll do is we will we can go down, and Is it okay? I will run down first.
Yeah,
Sure.
for
so,
sure.
I cannot tell you how important that this patient's privacy
No.
is maintained.
For sure.
It is. It's important to them. It really is very important to them. So we won't we'll go into a place where they're not, hopefully, and I think we should be clear on most places, but we'll be really sensitive about how we take a picture, because
For
just
sure.
in case there's a name that's written for some equipment.
For sure.
And if you when you're going through, if you see something that is any name at all, really please be sensitive.
For sure.
There's like an electronics facility. There's also a machine shop on premise. I don't know if that's of any interest to you.
For what was it used for? For
Maybe
the
I'll give you-
specific.
maybe
The
I have
specific
a couple
study,
questions.
not
Okay.
So
Okay.
this is Dr. Tran. He's not wanting to stop treatment because of xerostomia.
Xerostomia itself. Okay. And this is in a background. What kind of study? Sorry, can I ask?
Radiation. Just. Sorry. What do you mean? What kind of study?
Yeah. I'm just wondering what's the context of the study.
Oh, so we did. We've got this paper.
Oh, I see.
And these folks are interviewing us regarding just regarding the paper. It's for a student project.
Oh, I see.
But one of the questions they had was, have any patients ever decided to stop treatment because of xerostomia? And I just said I could not comment because
Yeah.
you would be the person they would talk to about
Yeah. I would say it's pretty rare. Like in my personal experience, and I've been a resident for 5 years, fellow for 1 year, and the staff for 1 year, so it's 7 years. Most of the time when they stop treatment, it's not because of xerostomia, it's because of other things. It's usually pain, they're not able to tolerate the treatments, nausea, and the xerostomia adds up to all of those other symptoms. So xerostomia happens, a lot of people just manage it with frequent oral rinses, baking soda mouth rinses.
Okay.
But xerostomia is definitely a bigger issue long term. So that's usually the thing.
So generally, you'd provide like medication to deal with the xerostomia. So it's not an issue.
No, it's more. Xerostomia is usually managed with frequent oral rinses, so it's not medications.
Okay.
So there are things that help, like xylitol tablets, some Silogox, so things that makes you secrete saliva. But we don't necessarily push it during treatment. In the long term, we might tell them to try those products, use artificial saliva substitutes. In general, the best thing that has shown reduction in xerostomia is improving radiation therapy techniques to minimize radiation to salivary gland tissues.
As you touched on. Yeah.
Any other questions?
That you are in physics, the master degree. Why do you end up in a hospital to do the medical stuff?
Yeah, I don't know how I got here exactly, but I did. So I came to UBC starting to do theoretical condensed matter in the physics department, not knowing anything about medical physics whatsoever. And then after a year, I decided that I suddenly became interested in medical physics, and I realized that there was a fantastic facility so close by that I immediately transferred and started doing my MSc in medical physics. So it was really just a matter of discovering the field that I was supposed to be in.
Cool.
So are you working on your PhD or?
Yes, yeah, I've got 2 more years of my PhD, so.
And is there anything that you'd like to add that we didn't ask you about? Anything you want to say about the article specifically, or anything?
Not specifically. I mean, we were a little disappointed to notice that we couldn't find anything. The purpose of the study was to split the parotid into different portions and look. Maybe this portion would be more important to spare than the other portion. We were really kind of disappointed to not find that, but we haven't given up on that. The topic of my PhD is taking that and going one step further, doing MR imaging and some other things, looking at finer ducts in the internal of the parotid, and maybe more functional to see how the parotid actually happens while you're stimulating. So taking a series of images over time, like a video of the carotid, but that's ongoing.
Okay. Interesting. And you hope to do the same kind of a study with cancer, like radiation therapy and the parotid parts that you're talking about?
What do you mean, down the road, or?
Yeah. So.
Yeah, that would be the goal.
Okay.
Definitely. It's something I would be interested in. For
Yeah.
Sure.
Okay, we can.
Well, you'll see the machine here can produce radiation. It can actually bounce and leave out the door. So,
Wow.
Not like
That's incredible.
not actually bounce, but it'll like ricochet.
Oh, okay.
So there are a lot of radiation inside this room.
That's right. The only person in the room during treatment where the machine is on would just be the patient.
Oh,
yeah, the other case.
Wow.
Okay, so if you want a linear accelerator, this. Do you want to explain this? You're the.
Sure. So a patient will come in and lay on the what's called a couch here, just this carbon fiber bed. Sometimes they'll be given like a motion or what are those called? Those
The back lock?
a vac lock. Sorry. So that will be formed to keep them in the same position, so that when they come back multiple times, they'll be in the same position. Sometimes they're locked down with a helmet or a mask or any other number of kind of motion reduction techniques. So they lay on the couch. The couch can move and slide. On a demo.
So,
Oh my God.
So you remember how he was drawing, the lines.
Yeah.
Yeah.
So those
Right.
rays will actually shoot out of here.
Yeah.
A pyramid shape.
The way he's describing it is a lot less sophisticated than it is. This thing currently
For sure.
has 100, between two. Well, I'm gonna say 122 moving parts that move simultaneously, or that change simultaneously to make a conformal.
Yeah.
To conform the dose. So if you were to look in here, I'll just show you. There's also this can turn.
Wow.
Okay. There is also, if you look in here, can you see these
Yeah.
things?
The line.
Oh, yeah.
Each one of these is a pair, and they will move all through the treatment. So what they do is they'll intensity modulate.
Wow.
Wow.
The math on each one of these is actually quite sophisticated in how to make something that is. It's incredible what they can do now. What we can do.
During the treatment.
That it's all moving simultaneously. So what we were showing you is slightly old. Now everything moves simultaneously. And this was it's a technology called volumetric modulated arc therapy.
Okay.
It was actually developed in BC, and it is the current state of the art for
Radiation.
centers all around the world.
But the thing that we showed you on the computer is the recipe for this machine. So the recipe will move around and deliver dose to the dose profile that we saw earlier. However it moves around isn't necessarily always specified by a human. It's kind of worked out from what the what's called prescription dose is.
So this thing is what varies the dose that you get
so
essentially.
the amount coming out, and then the shape of it can block some of it and not others. So and again, like this shape is specific, but this will be changing the whole way. I don't know if I have anything that could show you it.
It's okay.
But the whole time it's going around, it's doing this.
Okay.
So it's moving things in and out, and that makes a very specific, customized radiation dose.
Mm-hmm.
And then on top of that, we have this and this. This together is actually a CT. So we bring them in, we CT them while they're on the bed, and we line them perfectly. The CT on the bed to the CT that we planned them, and then they match exactly, and then we do it, and it delivers as close to exactly as we can.
Wow. It's amazing. That's so cool.
Approximately how much does this machine cost?
My guess on this
Yeah.
is 3 to 5 million. This is about as fancy as it gets. I mean, we also have this look watches them breathe. So if we're treating a site like lung, we watch them breathe, and we make sure that like we can deliver our radiation treatments only to certain points of their breath, and we're getting. The machine we're getting will even track the tumor, so it'll as the tumor moves, it will follow it.
Wow.
That's amazing.
Are the patient awake when they receive the treatment? So how do you prevent them from moving just a little bit?
So for any given treatment, 3 people will be involved. Well, between 2, but what we do, so we have things that do not take a picture of this,
Yeah.
but this
Yeah.
is meant to keep them, this locks them in place, right?
Okay.
For a head and neck, this is fit to that exact person.
Wow.
What is
That goes on them while they're on the couch.
Okay.
It holds them in place.
So what we do is we take, you take a plastic and you mold it around them specifically. What holds them here is designed to their body.
Right.
Right, so we vacuum fit something to them. It stops them for the most part. While it's treating, one person is watching the person. So if they move, we stop. We can re-CT and we'll go. An adult is quite good at it. And children, they have other techniques.
Okay.
Some children are also quite good at it.
How many machines are there like this here? Roughly?
I should know. I'm fairly new at this center, so
That's
I
okay.
don't. We have 4, 5, 6, 7, 8, 9 that I can think of.
Wow. That's incredible.
We also have other different modalities. Like we do a bunch of different types of treatments.
Just out of curiosity, is there a reason why those are there?
That's to
Make
just
them-
calm a patient.
Yeah, it
Calm them
makes
down.
them. I mean, essentially, yes, to make them feel better.
They also play music to just relax the patients too. But they're not in here for very long normally. So it's
This one kind of looks like emergency shower, but I
Oh
believe
no,
it's
this
not.
is this is just to help someone sit up.
Oh,
So
okay.
if they need a little bit
Okay.
of get up.
Yeah.
Yeah, but you're right. Same kind.
I don't know if it's relevant or interesting at all, but there are lasers embedded in the walls up there also to just help make sure the patient is aligned. There's also a light that comes out to make sure that this is lined up with where you think you're going to deliver on the patient. There's all sorts of alignment tools and tricks involved.
Everything's to about. What we aim for is about 2 millimeters accuracy, under 2 millimeters. So our imaging systems are generally better than a millimeter. Like we can, but we aim for about the worst we aim for is 2 millimeters.
Wow, that's amazing. And so before the patients actually come in here, you'd have their saliva measurements done, and
That's
then
right,
they'd okay.
Yeah. And then afterward also, after they're done treatment,
And
down the road 3 months.
One, yeah.
So essentially, we're trying to figure out if we can make their treatments just a little bit better,
But
right? Make it a little bit more tolerable. What they can do now, because we have all this shaping technology, we can. We're trying to get more information from any patient, just to make it a little bit better, to take advantage of all this other stuff that we can now do.
yeah. Oh, that's really cool.
One of the fantastic things about this is, it's a combination of physics, radiation oncology, and dentistry, and we have people from all each of those faculties
How
helping.
do you guys communicate? Because you guys have like different jargons and different languages, kind of, right?
Yeah.
Yeah, physicists and radiation oncologists, we do actually, like, if you get into this type of job, if you come from physics, you have to spend, like, So first of all, you'll come from medical physics. Medical physics is physics that's kind of designed to be in here, or diagnostics.
Okay.
That's weird.
So you learn about that, and then you do a clinical residency, and that's a 2-year residency where you essentially do all clinical work, and by the end we speak very, very similar.
Oh, okay.
Okay.
Dentistry, I haven't spent that much time in dentistry, but again, these are dentists that are they know radiation therapy, they know chemotherapy, so
Right.
they're specialized dentists as well.
And the building's not that big.
That's
See
right.
everyone in the hallways. Everyone kind of speaks the same language.
You can't see it, but there's also another imager down there too.
That's amazing.
Imaging's quite.
Can you take a picture of that?
Oh, sure.
Is that okay?
What is that?
Picture of that. That's so cool. That's pretty sweet.
See, this is besides that. This is when they're watching the patient. Camera.
Wow.
Right. So
There's a
Just
lot.
shift the couch a little bit, just
Yeah.
to show that degree of freedom. I think that's really cool.
Oh, wow.
So, I
Even
mean,
this
it's-
thing moves.
What?
Oh, wow.
It's,
This is crazy.
you know, and
You do have to be very careful because you can't arrange it such that actually the machine will collide with the couch if
Oh.
damaged. So
Oh.
you do have to be very careful.
Right, yeah.
so there's that. That's our.
The CT part of it.
That's the imaging system.
Wow.
Do you program, or do the person who operate this program or the movement before the treatment start, or
All
is there
what
someone?
you saw up there, like that plan, so that was a it's called inverse planning, but it's an optimization problem, and that, like, everything that's going to happen in here has been mathematically described outside, right? So every motion that's going to happen, everything that's going to happen has been the math has been worked out for it. This is essentially why we have physics in a medical department, because there's a lot of this kind of thing. Have you seen there's a good we can try and find it. There's a good thing in Vimeo about a guy who he videoed his own treatments on a machine like this with the same treatments that we kind of do. I expect his was for a brain cancer. You can kind of tell, but we can go and find it, and it kind of shows you
Sure.
what's actually happening.
That'd be cool.
Yeah.
Yeah. That'd be cool.
Okay, I'm just gonna send the stuff back to where.
Okay. Oh, can I just take one picture of that's twisted?
Yeah,
Sure.
while it's
Yeah.
twisting.
Can I?
Yeah.
Can I? I'm just gonna. We have a
Yeah.
You see, there's a little. I'm gonna move that stuff from the back, and that way it looks. That way it's not in.
Yeah.
I'm just gonna move.
Thanks so much.
Again, I can't tell you how important it is to not get any of the blue.
Right. So.
That is so cool.
So. It's just.
Yeah, look. That looks like great. Thank you. I do really appreciate you respecting the patient's
No, of course.
privacy.
For sure,
For sure.
It's hard to say how important it is to you until you've been there.
Yeah, fair enough. The thing is so cool.
Wow, it's like
Well,
so
cool.
moving.
The thing is, it's several tons, dude. It's
Yeah.
not a light machine. It's very.
It's
looks
this doesn't actually. This doesn't really sum it up, because everything on here, the imager, but everything is working together in here.
Okay.
So it's neat, and it's kind of how we used to do things, but now it's even fancier.
Yeah. It looks so
It's so
fancy.
cool.
Where they couldn't pour as much content, so they're all very, very thick.
And
sealed.
you notice how there's a, like, we go down a path so that there's no direct. That's also intentional.
Okay.
It's quite a nice recycling outdoor.
Yeah, this is like we have an even bigger door.
This is small.
Well,
There's bigger ones?
compared to the other.
Wow.
Is that every patient is an, like, it's decisions made here are for what the patient, like, I know Hal said that it's inexpensive, and it is relatively inexpensive for it, but I think any decision here is made for the I've never heard of someone saying this is cheaper, let's do this one.
Yeah, yeah.
Wait, does the
This
patient
is
need
the
to
best.
pay the hospital for the treatment or?
No, this is all
Covered.
This is tax
Covered.
dollars, yeah.
Okay.
Cool.